colleagues on as well. I'm not going to spend time on introductions, just conscious of time, but Maddie and Stella. Maddie, Stella, if you can just answer any questions in the chat that might come up during the session. So I'm going to share my screen, and this is going to be a mix between a PowerPoint presentation and I'm going to attempt a live demo. So everybody knows what could happen in live demos, but I'm going to try one anyway. Okay, so bear with me. I'm hoping everybody can see that.
Yeah.
Right. Presentation mode. Okay, so just a brief intro of where we are, how we've got to where we are. So I've been with the business sort of best part of 7 years. When I joined 7 years ago, we had 80 practices using eConsult. Today, 28 million patients serviced, 3,000 plus practices, and we've processed over 25 million consultations to date with a run rate of about 1.5 million a month. And that 1.5 million run rate has been reasonably stable now for the last 6 odd months. So as a business, we've moved a lot in this space, and we've learned a lot in this space in the last 7-8 years. Initially, I just want to very quickly walk through the high-level workflow, just so everybody understands what eConsult does without going too detailed into the product. So as a patient, I would access the platform either via the NHS app, where we are fully integrated, or with the GP practice website. In whichever the chosen modality of entry, they can use NHS login. So if they've got NHS login credentials, which they should have already if they've got the NHS app, which is about 50% of the population now, they can use those credentials, and a significant proportion of the demographics are populated within the consultation, but also the NHS number is captured in the consultation that's passed through to yourself. And as a practice, you can determine your custom availability. So whether you choose to configure your opening hours or your capping numbers, it's completely your choice. Now, the first step for patients is we try and walk patients through sort of self-care and signposting options. And that's a mix between self-care advice, which is derived from nhs.uk, local pharmacy finder, any locally commissioned services that you may have, and a symptom checker. And we find about 15% of patients use those services and signpost themselves away from general practice. Now, for the patients that do start a consultation, for the users of eConsult on the line, if you're not used eConsult before, we've got integrated red flagging within the platform itself. And that's really just to filter out patients that we would deem unsuitable for an online consultation journey and signpost them to a more appropriate, higher acuity environment. And that's about 11% of patients at this moment in time. And I'll go over that in a little bit more detail in a later slide. Now, once a consultation comes in, it is managed by the practice team, and we do strongly advocate a multidisciplinary approach here. 3 or 4 years ago, this was very much a GP-led exercise. Actually, we find now the practices that use not just eConsult, in fairness, online consultation tools well, are working with the multidisciplinary team and making sure that the most appropriate clinician is reviewing that particular presentation from a patient.
Sorry, Aman, somebody's asking if you could speak up.
Speak up. Okay, I'll do my best. Yes, so we would strongly recommend that goes to a multidisciplinary team. Now, when it comes to patient management, we've got a range of patient management options. And again, I'll show those in a little bit more detail throughout the presentation, but you can manage a patient completely remotely. You can send them a message via either email or SMS. We've got integrated telephony and video consultation options. Or alternatively, you can go back to type. If you think you need to bring the patient in, you can put them in for either a telephone or a face-to-face encounter. And we found, particularly during COVID, that we've seen remote management rates climb to between 70 to 90% for a number of users. And when I say remote management, that means in the absence of a face-to-face encounter. And I appreciate a lot of that is driven through COVID, but actually what we've seen is the capability of and the confidence of clinicians who are managing eConsults to really think about, actually, do I need to bring the patient in, and feeling much more confident, particularly with throughput and experience, to actually manage the patient at arm's length. Now, if I just move on. Now, as a platform, why do we think we're different? So we built a platform that we believe was amenable to remote treatment episodes. And what that means is that we weren't trying to build something that was a light touch, 2 or 3 free text questions that gives a clinician some information, but really just facilitates a secondary contact to close out the remaining detail. What we've always wanted to do is grab a structured history from the patient, a history that would very much mirror a face-to-face consultation. So you've got that structured history, and not only does that allow you to have a better quality data set that comes in from the patient, but it also allows us to start embedding that sort of that risk mitigation and that red flagging. And we do use a mix, so it's not just sort of structured history. We've got some free text where it's appropriate. We've got sort of binary questions, confidence scoring, multiple choice, integrated questionnaire sets like BHQ-9, GAD-7, BMI, Epworth Sleepiness Score. The red flagging, which I'll talk about in a moment, and also photo and document uploads. So the whole suite we consider as something that is robust enough for a patient to provide a high quality level of information for you to make that remote management decision. All of that is underpinned by a really structured, bespoke change management approach, because actually the reality is, and I know this from experience, a system is only as good as the end user's confidence capability to execute how it should be worked. And a really good platform that's not mobilized and deployed particularly well will actually just provide poor outcomes. So we've invested a lot of time, effort, and in fairness, a lot of money into a transformation team and transformation modules that really support practices and understanding where the value from eConsult comes from. And this is a little bit of an ongoing exercise. You know, we keep on learning, so that even the change management piece, a bit like the product, is very iterative, and it changes with changing circumstances and the changing needs of patients and practices. Now, if we move on, I just want to talk about the clinical elements and the clinical safety side. So if you imagine this bar across the top is the totality of the consultations that come through to practice, not including those that are diverted away to self-help by the patient themselves. So this is the total element of all consultations. If you imagine this is an acuity scale from left to right. So the further right you go, the higher the acuity level. On the far left, you've got the low acuity presentations that can be identified very, very quickly from the structured templates and very safely can be diverted away by a clinician or health navigator to a more appropriate resource. So that may be, you know, pharmacy, for example, or self-care. This yellow bar in the middle highlights those that are absolutely appropriate. They're in the right channel, they're using the right system to go and consult with their practice. And again, acuity scales moves up. As you can see, this box on the far right hand side here, this is where within the actual eConsult report, we make use of flagging and symbols to highlight areas that, although the consultation may be safe to present to practice, but areas that we think need particular attention. And that again is designed to support a more efficient triage decision by the practice. And then beyond that, we look at presentations that are unsuitable. About 9% of patients who present may be suitable. We don't have enough information from the patient to make that determining decision. So what we say is, okay, look, yeah, we think you need something more or quicker as a response from your practice or from a healthcare professional. So we direct the patient to either call the practice or call 111. And then you've got the 2% right at the end. That's your emergency red flags. That's where a patient is absolutely unsuitable and we think they should be in a high acuity environment. So, you know, we will direct the patient to call A&E or attend an A&E or go to 999. Okay, and that's kind of the breadth of how we operate. Now, if I move on, I just want to give you an example of that sort of breakdown within the consultation report. So this is an eConsult report, a typical report that comes through to practice, typically 2 to 3 slides in length. You've got the patient demographics in the top left. You've got their contact details just underneath. You've got a prescribed response time based on the chosen response time dictated by the practice. And then you've got their history. And what you can just see is down that left-hand margin, we use a series of symbols to highlight areas of specific interest. So the speech bubbles are free text. The exclamation marks here are things that just need some attention because they could be pertinent to the patient's presented complaint. And the red flags are actually, you need to look at this quite urgently. And again, all of those are designed to help make a much speedier triage decision. And the advantage you have here is if, for example, this is a rash template. Once you've seen a dozen rash templates and you know the structure, actually, it's much quicker for a reviewing clinician to highlight the areas of particular importance. And then the last one here is there's a photo that's been uploaded, which is actually a photo of my arm. And you can see the vitiligo on it. I'm just going to move on. Now, in a moment, I'm going to talk about the smart inbox. And the smart inbox is the most significant product development that we've made probably in the last 24 months. It's not out yet. It's currently in beta testing, and it will be rolled out to all users towards the end of September this year. but I wanted to just kind of highlight the differences of how we are operating with the Smart Inbox. Today, as a user, and I'm sure we've got some users on the presentation today, you're either getting your eConsults delivered by email. If they go via email, they're going into a nominated mail account. They're not patient matched and they're non-coded. That would mean that somebody in the practice, typically the admin team, would extract the eConsult from the email, attach it to the patient record, create an appointment in the appointment book, and workflow it for clinical review. A number of practices have got direct integration with Mesh, and that's for both EMIS and System 1. That's where we push the consultation directly into workflow. It's patient matched, but it's non-coded. Now, that has its strengths because that means that you're not dealing with another interface. The weakness is how that consultation is consumed is completely at the behest of the clinical system providers, because actually all we're doing is processing it, depositing it in the clinical system. How it's presented in the clinical system, we have no control over. It is completely down to EMIS or TPP. Where we're going to is this bit of middleware, where we're going to be using partner APIs with both System 1, with both TPP and EMIS, and that will allow coded patient match presentations and the ability to write back a fully coded outcome back into the patient record. So it's a real step change in integration. And the reason we can do that is actually we're processing the consultation here in the Smart Inbox, and it's not being processed in the clinical system. So we have far greater levels of control in regards to how we can sweat the APIs, because actually they're all sitting on our side rather than the practice side. And we can control how it gets written back into the system. Now, I've referenced this a couple of times already, the Smart Inbox, and after this slide, I'm gonna show you a real live demo of our beta environment. The beta environment is exactly that. It's still very much in dev. We are running weekly sprints on it, so it's evolving week to week. This is an interpretation of what the final product that we're gonna be releasing in September will look like. So just to give you an idea, this is a complete cloud-based system, so there's no local installs. Within that, your consultations will all land in a central queue. You can filter and sort that queue against a number of criteria. You can see all your triage information along here, and you can also shortcut the triage information to highlight key areas. You've got a signposting section here. This is where you can signpost to a wider multidisciplinary team, and you can identify levels of acuity, so you can put timelines for response. Completed consultations are fully coded back into the patient record. So you would manage the consultation within the Smart Inbox. The outcome is coded here, and once you tag complete, it codes back into the patient record. You can fully customize your views. You've got integrated messaging here. So email and SMS is going to be integrated in the Smart Inbox, and seamlessly, by pulling the patient record, you'll be able to send a message direct to the patient. And again, that will get coded back into the patient record. You can also create custom templates and store those locally. And the last section, just to highlight here, is it's what we call the logbook, and that's your ability to collaborate around your practice. So whoever makes a change within the signposting elements, that is captured within the activity log. Any comments that are noted are captured here as well, and anybody reviewing the consultation can see what's been done on it so far based on amendments, triaging decisions, and any comments made. Okay. Now I'm going to stop the share now, and I'm going to try and move to a live demo. So I'm going to cross my fingers and hope this works well. So share back in, different screen. And I'm hoping everybody can see that. This is a test practice. So not a live practice, but I'm just going to use a test practice just to show the workflow. So as a patient, I would enter, and I'm just going to pick a reasonably common complaint, something like back pain. Here we've got the integrated signposting options, pharmacy and self-help advice, as well as a consultation option. If you had a self-referral to physio, for example, you could drop that in here as a local self-referral option. But I'm going to use the last option here. I'm going to confirm that I've read the privacy policy. As a patient, I'd move on. Confirm this consultation is for myself. Confirm that I haven't got any of these urgent symptoms. And if the patient declares they're suffering from any of these, we'd stop the consultation immediately, signpost them to 999 A&E. I'm going to say I'm not suffering from those. As a patient, again, as I've already advised, you can use NHS login, or you can continue as a guest. I'm going to use my NHS login credentials just so you can see how it flows through. So give me a moment. Let me just log in. Irritatingly, I should have remembered, asked it to recall my login from previous uses. So 149 869. Just tag that so I don't have to do it again. Now it's going to accept my credentials and it's going to pass me back into the consultation. Now you will see across the top it'll say, according to your NHS login details, you're not registered at test practice. Obviously, I'm not. My local practice is actually in Epping, where I live. But for the purposes of the consultation, I'm just going to continue. So sex male, my date of birth has been pulled from my NHS login details. I'm just going to put in some dummy information here, just to allow me to proceed with the consultation at pace. I'm going to say I've not tried anything for this in the past. Any particular help I would like? No, in this instance. And again, I'm just going to, as I said, just dummy data just to get through this at relative pace. My back is painful. No, no. Say moderate back pain, so I'll give myself a pain score of 5. It distracts me, but I can carry on usual activities. It doesn't keep me awake at night. I didn't injure my back. I've not got pain in my lower back. Again, just for the pretext, I just put in test. Am I able to walk 4 steps? Yes. How long have I had the current symptoms? I'll advise 4 to 6 days. Any weakness in my legs? No. Any pins and needles? No. Any incontinence? No. Any loss of control of my bowels? No. Any numbness in my bottom area? I just wanted to show here where the integrated red flagging presents. And back pain's a really good example where a patient may present with back pain and not really understand the clinical severity of their symptoms. So a lot of back pain may be just musculoskeletal. I'd expect it to be muscular pain and probably alleviated with analgesia and some physio. In this instance, I'm going to say I've got numbness in my bottom area. That immediately stops the consultation because it could indicate a risk of lower spinal cord avulsion. So we don't want to pass that through to the practice because actually we don't know the severity of the patient's condition. It may be that the practice has got a variable response time and we don't know when the practice is going to triage that consultation and revert to the patient. So as soon as the patient enters consultation here, we'd revert them to more appropriate environments, typically higher acuity environments. Okay, but I'm going to go back in this instance and I'm going to change my answer to no just to get through the consultation. I haven't got temperature, no profuse sweating, I've not vomited, no blood in my urine. Urine is not cloudy, doesn't sting when I pass water. I'm passing water normally, not had problems with my back before. And this is another really good question. So any unexplained weight loss, if a patient were to tag yes in this, we would push it through into the consultation report with a red flag because it could be an early cancer marker. So it's just, again, to help you identify patients who may not understand that rapid weight loss in the last 3 months is actually a sign of potentially of cancer, but just to be able to, for you as a clinical team to be able to look at it and say, actually, we do need to follow this up. So I'll tag a yes in that, for example. And again, I'll just put test. But no surgery. I want to upload a photo. I've got photo disclaimers here. So I'll attach a photo that's just stored on within my desktop. Use this one. And again, just a description, just dummy data. Anything else I'd like to add? Then we ask a little bit about your health, so your health background, any drugs a patient may be on, medication a patient may be on. My drinking status, I'm a moderate drinker. I used to smoke. Do you have any allergies? No. We ask a COVID question here. And now, although this allows the consultation to be passed through, the patient says yes. What it does is it alerts the practice that if you were to call the patient into a face-to-face encounter, that actually the patient's coming from an environment where COVID was present within the last 4 weeks. And then we take the last bits of the demographic details. And this is my name's been pulled through from NHS login. My address does not get pulled through. So that's something I do need to populate. So I'm just going to put our business address in. My contact details are pulled through from my NHS login details. I can request, for the purposes of continuity, I can request help from a particular member of the team. This is not a mandated request. It's a preference. It's your prerogative as a practice, whether you choose to honour that or not. You can make a decision from a continuity perspective. I'm going to say no. And the last part of the consultation from a patient perspective is just a couple of options that they have. They can have an option of having their consultation answers emailed to them, just for their own records, and they can opt into a one-time survey. And that survey is sent via a link to them 7 days after they submit the consultation. About 12% of patients complete that survey. and that information is then aggregated, anonymized, and shared back with the practices on a monthly basis. And that's just used to help. We use it locally to help support our product development, but for the practices, it's really used to think about how they can evolve the service delivery model. If there's weaknesses in the service delivery model, what do they need to do? And actually potentially reach back into us and say, what can we do? Because we seem to have a reoccurring theme, potentially. And that's it. That's your submission. It goes in as a patient. I'd get this information on screen. I used to get it emailed to me. I get a prescribed response time based on the practice's chosen response window. I get worsening care advice and just some best practice for the patient in regards to contacts from the practice. So that's the consultation end done. Now I'm going to flick across into the smart inbox. Now, as I said, this is completely cloud-based and access is via NHS Mail single sign-on. I'm going to log in via that. Try that again. I've already logged in today, so it's not going to ask my NHS credentials because it's once every 7 hours, but typically it would then take you to an NHS Mail login page. It accepts your NHS Mail login details and then pass you into the smart inbox. And this is what you would see. This is very much a beta at the moment, so it's not the final product. It's in development. We have got some beta sites using it around the country, and they're supporting our ongoing development of it. Before I go over the particulars of the consultation, I'm just going to quickly walk through an overview of the smart inbox. So on the left-hand pane here, we've got a segregation of consultations between clinical and administration, and that's based on the consultation type that the patient has submitted. And then those are then sub-indexed based on the status of the consultation. So a consultation that has been received but not worked on is going to sit in waiting. Somebody in the triage team may have looked at the consultation and decided it can wait because there's more important ones to look at, or maybe they're going on lunch or something, and they put it in snooze and they're going to come back to it later. The triage team may have looked at the consultation, thought that they need further information from the patient, sent a message to the patient and asked, and we're awaiting a response, or it's been triaged, ready for full management. And exactly the same from the admin side. And just across the top here, you'll see all open consultations and those that have been tagged as complete, i.e. completely managed, and then the outcome has been written back into the patient's patient record. Here you've got an option here to filter your queue. So this is your high level queue. You can sort it by time received, age. So some practices may want to see pediatric consultations first, the number of flags in the consultation, or the deemed urgency from the triage clinician. So now I'm going to go and find the consultation that I've just submitted. So if I go into waiting, and I go to the bottom, you can see this is the back pain consultation I've just submitted. If I click into that, I've got the unique consultation ID in the top left. I've got the time and date of the submission in the top right. I'll click this drop down here. I can see my details, so my date of birth, my NHS number, which has been pulled from my NHS login credentials, my sex, my contact details, and my home address. Also, you see a summary of the consultation. So you see a response time that's been determined and answers that need close attention or urgent attention. And in a very similar guide to the patient's presentation, you see their responses. So again, the free text highlighted by a speech bubble. These exclamation marks are highlighting areas of concern. Unexplained weight loss has been marked as with a red flag. So again, potential cancer mark, as I detailed earlier. And then the patients confirm that they're happy to upload a photo and they've accepted the warning signs that go with it and which type of photos not to upload. We've got the health history and the cough details. In the final product, all your cough information will be fully coded back into the patient record, so there's no manual coding involved here. And lastly, the image that I submitted. Now, once this is ready to roll out, from a coding perspective, static codes will get coded fully in. So that's consultation type, so online consultation from online channel. It will be things like your PHQ-9, GAD-7, BMI, all of those things. BP will be fully coded in because they're static codes, and your cough information will be coded back in as well. And then the last part I just wanted to walk through is the signposting option. So here, as I review it, as a triage clinician, I can look at this and say, okay, who do I want to assign this to? Okay, it's a back problem. So maybe if I've got a physio available, I can allocate it to my physio. It's got some moderate level of pain. So I could say perhaps it's not super urgent, so maybe a 48-hour response is suitable. I can recommend a modality of contact. And because of the cancer marker, I may want to say, okay, we're going to do face-to-face because we're just going to explain to the patient that we may need to undertake a referral. In that instance, I'd probably revert the physio to GP. Here we've got consultation type. It's defaulted to clinical because it's a clinical presentation, but actually you may deem it to be admin, so you can override that, and you can change the status. So I'm going to change the status here to triaged. So now it's triaged and it's pending completion. And I'll leave a comment. I said triaged 48-hour review. And I'll save that comment. And if I save all those changes, see that consultation is now kicked out. Now, if I go back into the smart inbox now, as a clinician who's now managing that consultation, I go into the triage list. I look at all of these that have been triaged, and then I can filter out. I can say, okay, I'm going to filter out by either team or urgency. I'm a GP. I'm working today. I want to see the GP queue. So I look at the GP list. I apply that, and at the bottom you can see that consultation that I've just allocated for the GP to review. So I go back into it. Now here, I've got the same chat. I've got the same information. I've got the decisions that have been made by the triage clinician. And I can see all of the activity on the consultation within the smart inbox. So it's, the status has been changed, who it's been assigned to, response time, modality of contact, 48-hour review, and any comments that have been left. Okay. Now, very much in development. There's a lot to be added into this. This is not an integrated version, so it currently doesn't talk to any of the clinical systems. Witness tests for both System 1 and EMIS are planned for the end of July. So we are hoping to have an integrated version live and ready to beta test by mid-August, and the plan is to sort of roll out in September. And this will go, as I said, this feature would go to all practices. So I'm going to stop the screen share and I'm going to revert back to my presentation. Display mode. Right. So just a few other options. Some of you who may be using eConsult may already be using our toolbar. The toolbar isn't going away, it's still there. The messaging functions within the toolbar, so SMS and email, will soon be integrated within the smart inbox, so there'll be less dependency on messaging from the toolbar, but the toolbar will still be valid for use on video consultation and telephony. But those options will sit from the toolbar rather than the smart inbox. Customization, lots and lots of customization options. The most commonly requested are the ability to amend your response times. And those response times can be end of the next working day, same day, 2-hour response. There is also some capacity to extend your response window, but we typically ask our clinical governance team to have a conversation with any practice that wishes to extend their response window to up to 3 days. Choice of template. So a number of the templates can be activated, deactivated based on practice choice and practice workflows. So that includes pediatric content, chronic disease and review templates, and a travel template. And the most commonly used feature at the moment is demand management feature, which allows you to manage demand via a planned activity or ad hoc activity. So ad hoc allows you to snooze the consultation engine. And that means that as patients, as a practice, you may decide that we've had too many consultations today, I haven't got the resource, I'm going to snooze the consultation element of the platform. But patients who enter can still use the self-help and signposting options. Or you may choose to cap your volumes, and you can cap up to a select number. And once you hit that cap, the consultation engine is shut down. And again, patients are advised when the platform will be available again. But again, the self-help and the signposting options are still available. And the last part of the consultation, or the presentation rather, I'm going to go through is just the ability to create your own eHubs. We created our first ever eHub within the Hurley group about 5 years ago. And that hub has evolved several times since it was created. It was first created as a physical hub, and it was what we called a secondary hub. So a secondary hub meant that the consultations went to the practice, and the practice would then make a decision as to the ones they wish to keep and the ones they wish to share with the hub. It's always been using our core platform with a series of workarounds between clinical system and in fairness, Outlook rules, which we're now trying to remove with the smart inbox. But that hub has now evolved. It's now a primary hub. So that means every single eConsult within the group now goes to the singular hub. And it's a virtual hub as opposed to a physical one. So instead of having a bunch of clinicians in a room, We now have everybody working either at home or within their own practices, and they're working 100% remotely. We support the development of 10 e-hubs across the country. We're pretty confident this is the direction of travel for most online consultation provision nationwide. And the big thing from us, from our perspective, is that, again, I've already referenced it, product is the enabler. Your processes are key here. And that every hub we've worked with, we've worked in meticulous detail to evaluate their processes and make sure that they are ready to federate their service model with online consultation. That will become easier with the smart inbox, but it still needs a lot of development work. So as we start rolling out e-hubs, we're working on a product and a business change element to both of them. And the business change element typically runs from 6 to 12 weeks, depending on the capability and the capacity of the practice, or the PCN rather. Then what we've seen is you get a consistent patient management experience. I think resilience and retention is really, really key. Just the offer of having to be able to offer 2 or 3 sessions a week from home is actually quite a significant pull in modern day society where, home life is complicated. You've got 2 working parents and they've got childcare needs, or you've got elderly relatives you may be looking after. Having the flexibility of doing some of your work from home and not having to be in practice is actually quite a value add. You get better synergy between your PCN or between your federation. It's easier to make better use of multidisciplinary team, which is particularly pertinent with the R's roles in play. And you can share the economies of scale. That's me finished. I've done a lot of talking and I'm hoping somebody's got some questions for me. So I'm going to stop the share. Thanks, everyone. So happy to take any questions.
Hi, Aman. I'm just going to ask you a question that was in chat, and it is around SMS. Can patients reply back and attach a document?
Yes, so two-way. It's not two-way SMS, and it's really important. The patient can receive a message via either email or SMS, and that's user practice sending it out. The patient then clicks a link within that message that allows them then to complete a response back and add any attachments. So they can add up to 4 attachments, whether those are photos or pictures of medication boxes or letters or whatever the case may be. So I'm hoping that answers the question.
Thanks. There was another question as well. Does the smart inbox mean our admin staff no longer required to download or import the messages?
Correct, yes. So what would happen is in the mature product, the one we're going to roll out in September, the integration will be such that effectively all your consultations will land directly into the smart inbox. You, as a reviewing clinician or managing clinician, I'd manage the consultation from within the smart inbox, and then I write it as complete and write it back into the patient record as a fully coded outcome. So there is no more extracting from mailboxes, adding it back into the patient record and workflowing it from there. That's one of the key things that we were seeking to remove, but we're trying to do it in a way that's adding management value for both admin teams as well as clinical teams.
Great, thank you. David Harding has asked about more information on eLight.
Sure. So eLight is available at the moment to practices via effectively clinical system protocols. We're actually integrating eLight within the smart inbox. Because that eLight is really for those patients that are struggling with online access, but actually you as a practice may have chosen to be total triage, and you decide that you want as much of your incoming presentations from patients in the same modality, but in the same structure that's been presented. So that really allows somebody in the admin team of practice to walk through a consultation with somebody on the phone within the smart inbox, and then have it workflowed for review as you review any consultation. And it'd be very clear in the output that the reviewing clinician would see is that has been submitted as an eLight template rather than an eConsult template.
Okay, we can also follow up and send you some useful guides as well, David, but you can always come back and ask us if you've got any more questions on that. Can online result requests be split by workflow to admin or clinical staff?
Absolutely, and that's really what the smart inbox is doing. So everybody would have the same. You would share an inbox effectively. So you've got a practice team. and I'm just going to throw some numbers. You've got 10 clinicians reviewing consultations, and you've got 10 administrators within the part of that team. Everybody would be able to review the smart inbox. At the moment, the way it's indexed is you'd have the split between clinical and admin. So, as an administrator, I would look at the admin queue. The next iteration is that you'll be able to sub-index that. So you'll be able to sub-index it right by individuals in your practice. So you could say, I've got, instead of just having a standardized GP queue, I've got Dr. Jones, Dr. Smith, Dr. Singh, Dr. Patel, and we've allocated work into them that matches the work that sits in the appointment book. So as a reviewing clinician, I just look at my queue. That's the space we want to get to. So you've got your own work stream, but ultimately it's a shared inbox, which means that if somebody can't look at the work, they call in sick, for example, on that particular day, or they're unexpectedly called away from practice, it doesn't stop anybody else going in and reallocating the work to another member of the team. So we don't want to shut down access. What we want to do is be able to create unique work streams that are proportionate to each member in the team, and ideally within roles and named individuals. But that'll be your customization. So you have sort of super user privileges, and you can customize that down to the nth degree effectively. And there is a danger, in fairness, of potentially making it too complex. So that's the reason we haven't done it in the first instance, because we really want to understand how users would use it. If we start sub-indexing, we may over sub-index, and there just may be a sub-index of a sub-index, and suddenly you're looking through several layers of a queue trying to find the consultations. And we certainly don't want that to be the case. But the segregation is a big part for us, because we know any practices that are currently using mesh, everything goes into the same place. And typically, particularly with EMIS, they've got the same naming convention, which means that you almost need to do a pre-triage of the correspondence before you can determine whether the correspondence is an eConsult or a discharge letter. So I hope that answers that question.
Thanks, Aman. There's a question coming through from Julie Beer. Now, this is actually quite a broad question, so Julie, do feel free to clarify. But can you talk a bit about questionnaires, please, Aman?
Yes, it is a broad one, but I wondered if that, what was the scope for adding questionnaires onto
Julie, sorry to interrupt, Julie. When you say questionnaires, do you mean as in consultation templates, or do you mean sort of feedback questionnaires?
Feedback questionnaires, sorry. Yeah, feedback questionnaires.
Okay, no, yeah, it's not a problem. So at the moment, the only feedback questionnaire we get from the patient is the patient experience piece on eConsult. But again, this is the great thing about the smart inbox. When you can start thinking about, if you start thinking about, I want to create my own custom templates, within that custom template, you can add a link to whatever questionnaire you want, and you can push that out to the patient.
Right, on the template.
On the so effectively, if you've got a friends and family test, and say you want to push that out to a patient after you've managed their consultation, you could create a static a messaging template which just links through to the friends and family test, and then push that back to the patient.
Yeah, it was kind of the friends and family that I was thinking of, just as an after experience thing to add that on for response.
And you can store that locally, and you can create as many as you want. The danger is, and the reason we've never done it historically is because, and I'm sure everybody on the call will understand, if I went to 10 practices, I'd get 50 requests for different templates. If I added them all on, it'd be harder to find the template that you want, because it's just such a long list. So what we've done is we've kept the standardized list quite short, but the customization is going to be for you at practice. You choose what you want to store locally, you build them and you keep them. They're yours. I hope that helps, really.
Yes, it does. Thank you.
Great. I'm just keeping an eye on time, just to assure everyone, if we don't answer the questions, all of them, then we can follow up after and make sure that we've got any of your questions or concerns all sorted out for you. What is the average time taken for patients to complete an eConsult?
Okay, so at the moment, the average time is, depending on the consultation type, admin consultations are about 7 minutes, clinical consultations about 12. We are doing some work, and you may have seen during the consultation, the QOF questions and the Your Health questions. We're going to add that in as a configurable. So you as a practice can choose as to whether you want to ask those questions or not, or if you want to ask them based on a time lag. So by way of example, if the patient submitted a consultation in the last 4 weeks, for example, we won't ask the QOF questions again or the Your Health questions again, because you have reasonably up-to-date data, and you can choose that configuration. So, and that's designed to really shorten the template length. In regard to time taken by patient, we're at a little bit of a paradox, in all honesty. There is not an easy answer on this, because it's the one bit of feedback we often get is that the templates are too long. And that typically comes from patients to say it takes me too long to complete a template. If I revert back to the rationale for eConsult, and that's to optimize it for remote management, what we're trying to do is get you high quality information in front of a clinician that's giving you the potential for a remote management episode. The danger we always have is if we lower the bar on quality and volume of information that's being passed through, the result is you're going to get lower quality requests in greater volume, which is actually just going to exacerbate potential workload. So we're always working that balance between how do you get the right information to a clinician to review, whilst also not asking the patient to spend 20 or 30 minutes or an elongated time doing the actual submission itself. We need to incentivize both sides. So we are actively, I think time to completion has reduced by 23% in the last 12 months. And it's one of the things that our product team has a standing agenda on, to keep on trying to drive down time to completion while still maintaining the quality of the output that comes back into practice. So it's quite a long answer to a short question. I hope that helps.
Great. Thanks.
Can I just add something to that? Sorry,
Sure.
as kind of a follow-up question. I totally understand in terms of what you're looking to do and create the high quality. How do we go about the change, the behavior change for the patients? Obviously, you've done this with other practices, and there's just, I mean, 12 minutes for for an elderly patient who doesn't use eConsult, etc. It's very, very difficult. How do you go about making that change, to a total triage model for everyone, really?
Yeah, so
Any hints or tips?
Yeah, no. So I think the biggest thing is that you as a practice will have to advocate the model, use the eLight templates for the patients that are struggling with online access. So, I'd often use my mother. My mum is a really good example of this, right? So my mum's 74 and she's quite tech savvy, first generation from India, quite tech savvy, fluent with English, that if language isn't an issue, on Amazon all the time. She's just booked a ticket to India yesterday. She's done that herself. Would she use eConsult? No, her practice has got eConsult. She wouldn't use it. And the reason she wouldn't use it is because her relationship with general practice is her relationship with her doctor, her GP. She wants that relationship. It's important to her. Now, actually, what I want is, that's fine, not an issue. What I want is the patients that are amenable to use an online channel to use an online channel. That frees up resources for the patients that are less amenable. So you're getting the patients in the right channels, not all patients in the same channel. Now, when it comes to a total triage methodology, a lot of it is really how do you do the patient education piece. So we can share lots of videos with you in regards to the value for patients. And the biggest value for the patient is, I think, online consultations had a little bit of a bad rep because it's deemed as lesser offer. So if you kind of go to the best offer I can get is face-to-face as a patient, then the lesser offer behind face-to-face is telephone, and my worst offer is online. Actually, a lot of the patient education starts with you're starting your journey with your practice online. You're not concluding it. Provide the information up front and you get a better, more robust episode from your practice, because actually your practice is better informed with the next management steps with you. They'll prioritize your entry into practice. You're not stuck in a long queue for a routine appointment. They'll understand what your needs are and they prioritize your needs based on the information you've submitted. And actually, you're not waiting for 20 or 30 minutes on the phone on a Monday morning trying to get through. You're spending 10 minutes at your leisure, sitting on your sofa, submitting a consultation. That actually means that the practice will come back to you when it's suitable based on your clinical presentation. So there is a big piece around the patient education on this.
Yeah, no, absolutely agree with that. I think once it's embedded into the system, it really can make a difference. In your, sorry if that's okay, if I can ask another question.
Of course.
In your kind of experience, how long does this change take usually? With implementing, with kind of average, obviously, not.
Yeah, I mean, it's a really difficult one. It really depends how much you facilitate it. So what you need is I think the clinical team really need to be brought into this. So to change, I think there was I was reading a study on behavior change, and it said something like you need 7 regular encounters to start changing somebody's behavior. Now, on average, that's probably what you see in general practice annually. So you could argue that it's going to take you a year to change someone's behavior. Now, the only way you can do that's very organic. If you want to make that more facilitated, then it's going to be you as a GP. Next time you see a patient with an amenable presentation, look, don't phone up. Please come in online. We're going to get you a much quicker response. Go to our website. You're going to see on our website. If you've got the NHS app, you'll see it there. Present there. We'll come back to you far quicker. And it's that regular piece. Every time somebody phones up for an appointment, the first question typically sort of the reception team would ask is, why do you want to see the GP? If they feel it's something that's amenable, ask the patients to go online. and then and then somebody in the team will triage and come back to the patient far quicker with a far more appropriate response. So facilitating that journey, that's a lot of the work we do with our transformation teams. How do you facilitate the change management? In very rare instances, I admit it's quite rare, there are a number of practices that have been really confident and they've gone total triage from day one. So they've launched and gone straight to total triage. I personally won't recommend that. I think it's a really high risk model. What I would recommend is that you start slowly, and you may start with, okay, I'm going to push all of my admin online. So every time somebody wants an admin request, I'm going to say, look, fine, can you please submit that online? That's the first step of behavior change. Very low clinical risk associated to it. Patients are going to get better experiences because they're not waiting 20 minutes on the phone to get an extension to a fit note or a hospital letter. And that's a really good way to start that journey. And then patients will you start doing what everybody does. They start perusing the other options. What else can I do while I'm here? And when they get one good experience, and that's what it comes down to, positive experiences. Positive experiences create further positive experiences. It's repeat. Repeat usage is based on your experience. If you get a great first-time experience, you're going to come back. Same as a restaurant. If the food is great, you're going to go back. If the food is terrible, 2 years later, might be under different management, you're probably still unlikely to go back. That first experience is really key.
Yeah, definitely. Thank you. Thank you.
No problem.
Great. Tita, how are we doing for time? We're on 53 minutes past.
So from our side, I mean, there's nothing else really to update on our side. So we're happy just for questions to continue.
I can see there's a few more, so I'm happy to pick those up. That's not a problem. So let me just have a look. Questionnaires we've gone through.
There's a good one about AI and smart triage protocols available.
Yeah. So that's okay. Good question. So we're looking at that for within the eHub. So within the eHub, and we've seen it as a particular problem within potentially PCN use cases where our model for the eHub is really to make great use of a multidisciplinary team across the PCN rather than just in practice. And typically that would mean that you would have a triage clinician at the front end of every consultation, just doing the allocation into roles. And I'm going to speculate this is the most expensive resource in the practice, but I'm saying if it's a GP, a busy practice or a busy hub may have a full-time GP just triaging work to other clinicians. If I costed that out, that's £100,000 a year on cost. The AI protocols we're working with in the first instance are going to be doing that allocation within the eHub. They're going to be doing that allocation via AI. So we're working with Deloitte Health. Deloitte already have this within healthcare in Scotland within outpatients, and we're currently repurposing that bit of AI and training it for a different type of presentation. We're determining accuracy of allocations versus a clinician undertaking the allocation. At the moment, we're at just north of 75%, and the target is to get to 95% before we can think about rolling that out. But we think that that's actually a huge dividend because that's a great upfront saving just in the allocation of work to the right role. There are a lot of future use cases of AI, and we're already exploring with Deloitte what are the future ones. At the moment, it's going to be a little bit of baby steps. Let's get the first thing in working, make sure it sticks, and make sure that it's adding value. And then there's lots of other options about assigning acuity, for example. What does that look like? Or actually assigning work outside of the PCN group. So we're working quite closely with the CPCS team, and it's just digital. And the first bit of work we're undertaking with them is just to capture the patient consent to have their consultation referred onto our community pharmacist. But the next bit will be actually how do we put a smart inbox in the community pharmacy? The AI now triages the consultation, pharmacy is suitable, puts it in the right community pharmacist queue for that patient. And then when that community pharmacist team, when they go into their smart inbox, they only see their queue. So we can really start thinking about allocation in a far more sophisticated manner. But the first stage, which is where we're targeting to be launched in sort of September, October this year, is going to be the allocation into roles. So I'm hoping that answers that question. Where else have we got? Will there be a function for patients to self-book via a link sent to the patient? Yeah, yes, there will. We're working with GP Connect. That's not in the short-term roadmap, so I just want to be clear on that one. We are actively looking at it, but the likelihood is that's not going to land until sort of back end of this financial year, so Q4, probably likely to be February, March at the earliest at the moment. But it is something that's been actively looked at by our product team. Time taken, we've done. AI, we've done. How can admin receive? Okay, we've done that one as well. Are there plans to develop more review eConsult templates? Absolutely. Just tell us, guys. I think it's a feedback piece here. Tell us what you need. We've got an in-house clinical governance team that work, and their job is to build content, peer review content, and make sure the content is the existing content is up to date with and in line with national guidelines. So, these guys are working on templates daily. So if there's stuff that you need specifically, please, feel free to send us an email. I'll put our contact details in the chat, and I'll be happy to, or one of the team, myself, one of the team, will be happy to pick up with yourselves and see what else we can do about adding further content. That's not really a problem. Yeah, and I think that Tracy's note here about just joining up with the digital map is key. I think, the big thing for us is we see the connectivity beyond general practice here. So the smart inbox is a significant development for us, not just because of what it does to general practice, but actually we're already developing a version for this for outpatients, where we're doing quite a detailed bit of work with Mid and South Essex Foundation Trust to completely digitize their outpatients offer and create a virtual outpatients offer and centralize all of their admin functions. And we're having a couple of conversations with trusts around, can we use a version of the smart inbox in their EDs to consume patient submitted information? And the idea here is we want to connect those doorways. So, one of the, my personal opinion is one of the weaknesses in the system is that, and actually there's, in fairness, there's a lot of data to back this up, is that patients, I think something about 40% of patients present in front of the wrong clinician first time. And how do we change that? How do we move the data, not the patient, to the right clinician? So we're trying to connect the doorways here so we can actually start moving data through the system so we can get the right information in front of the right clinician as quickly as possible, and therefore facilitate an appropriate and a timely health intervention. I've got one of Tracy here. Do practices usually recruit additional staff to implement total triage? Tracy, no, they don't, in fairness. The total triage model, and again, I'm happy to introduce you to our transformation team. It's a complete change of how the practice operates. Using the existing team, very rarely would a practice recruit new people to run a total triage model. Early on, very early on, I think a couple of the first practices did recruit an additional administrator. But that would, the ones we've done in the last sort of 12 months, I'm not aware of anybody that's recruited any additional headcount. Got one more here. If the patient calls the surgery after submitting an eConsult, will it be opposite the triage process is underway, or will it be visible in the notes once completed? If the patient calls a practice to determine the process, the triage process, again, it will sit in the smart inbox based on the status. So you if I was sitting on in the admin team and somebody called me through and said, oh, can you tell me what's happening in my consultation? If it's sitting in waiting, that means nobody's looked at it yet. If it's been moved to a separate queue, that means the triage process is in flow. If it's in triaged, that means it's been triaged to a particular clinician to do the full management episode. And in that instance, the patient will probably get a response quite shortly. It wouldn't be overtly visible to the patient, just to be clear. It's only practice side. So I just want to make that one clear. Farah, how do I contact the clinical governance team? Farah, I put our contact details, so commercial@econsult.health in the email in the trail. Please just drop us an email and we'll direct you on.
Well, if that was the last question, I think you timed it to perfection.
There was always a plan there, I'm sure.
Well, I will just stop recording.